Thank you, Shirley, for that very powerful welcome to country. Good afternoon, everyone, and a very warm welcome to the Abraham Conference. The Abraham Conference is an annual event that brings Jews, Christians, and Muslims together to discuss contemporary issues of concern for the Abrahamic faiths and for wider society. This is our first online conference, and we are so happy that you could join us. The Abraham Conference is organised by representatives from the Affinity Intercultural Foundation, the Columban Centre for Christian-Muslim Relations, the New South Wales Jewish Board of Deputies, the Uniting Church, AMUS, the Catholic Diocese of Parramatta, the New South Wales Ecumenical Council, the Australian Egyptian Forum Council, and the Indian Crescent Society of Australia. Our committee managed to meet face-to-face just once this year. However, we have continued to plan this conference monthly via online meetings. Our wonderful committee is truly a testament that through respect for one another's differences and an awareness of our commonalities, nothing can stop us, not even a global pandemic. A special thanks to our tech genius Dash and Plus 61J Media, who helped us transition this event online. From our very first meetings, we knew that the theme of this year's conference would focus on the dedication and resilience of the Australians working on the front lines of crisis. As a result, our speakers are from various medical and allied health fields. I think I speak for all of us when I say we are so grateful for the dedication of our medical personnel who've had to respond so rapidly to the challenges of COVID-19. We thank Dr. Daniel Fleming, Ranata Leremias, and Dr. Haroon Kasim for being our speakers today. And we look forward to hearing your stories about the challenges you have encountered and how your faith has nourished your approach to your work and your relationships with others. I will now hand over to my colleague, Zia Ahmed, who will introduce the legendary Rachel Conn, our moderator for today's conference.
Thank you, Kate. My name is Zia Ahmed. I'm Editor-in-Chief of the Australasian Muslim Times AMUST and a member of the Abraham Conference Organizing Committee. It is my honor and great pleasure to introduce the moderator to the Abraham Conference 2020 today, Dr. Rachel Conn. Rachel is best known to Australia as the voice of the Spirit of Things on ABC Radio National, a program she produced and presented for 21 years. Over her 26 years at the ABC, she spoke to thousands of people about their beliefs, their values, their experiences, and how they contribute to making a better world. Rachel has written books and articles on almost every aspect of religion and society, and has presented these at many conferences internationally and in Australia. Dr. Conn has received many awards, and in 2019 was awarded an Order of Australia, AO, and was made a member of the Royal Society of New South Wales. She is here with us today to moderate what will be a fascinating set of presentations and discussions by leaders in healthcare from the Jewish, Christian, and Muslim communities. Ladies and gentlemen, Dr. Rachel Conn. Thank you.
Thank you so much, Zia Ahmed and Kate and Shirley. It is a great honor to be here and such an important time in our lives. Welcome all of you to this annual Abraham Conference, Interfaith at the Frontlines. 1 week ago, a great light went out in the interfaith universe when the former chief rabbi of the UK, Lord Jonathan Sacks, died. It was a great shock, but fortunately he left a great legacy, many books, many columns, and of course his activism. I would like to remember him today because years ago, when Australia faced a particularly tense time with relations with the Muslim community, I interviewed a visiting imam from the UK, from Brighton, a coastal city in England. And he said to me quite spontaneously that Jonathan Sacks' book, The Dignity of Difference, was his Bible in interfaith work. I was so touched by that. Today, the Abraham Conference will hear 3 speakers from the Jewish, Christian, and Muslim communities. They've already been named. They are, of course, very different, but they have one thing in common, which is their dedication, their work to help Australians in need, in medical need, in psychosocial care, and in welfare need. It all is one big bundle, particularly this year. But another book by Rabbi Sacks was called To Heal a Fractured World. And I think we can all agree that 2020 has been a fractured year, and the world has certainly been fractured by the coronavirus and its knock-on effects. In To Heal a Fractured World, Sacks notes something quite surprising, that many of the great figures in the Bible, from Moses to Isaiah, Jonah, and David and Jacob, all doubted themselves. In one way or another, they asked, "Who am I, O Lord, to carry out your tasks, your work?" Sometimes we are surprised that such great people doubt themselves. Yet we all ask ourselves that question at one time or another when we are in the midst of seemingly insurmountable tasks, or when we are facing new ones we have never encountered before. And our guests today must have asked themselves that question and wondered whether they were up to the task, which indeed they have all carried out with distinction. But self-doubt, rather than being a weakness, is exactly what allows them to recognize and be alert to the doubts in others, the fears in others, the weaknesses that they are experiencing. For how else can we help people if we do not understand and feel what they are feeling? It is one of the great teachings which our traditions share, to reach out and to help people in need. Our first speaker today is very well apprised of that world of need. She is the Senior Manager for Children, Family, and Community Services in Jewish Care. Ranata Leremias holds degrees in social work, in art therapy, in trauma-focused psychotherapy. She holds an advanced diploma in community sector management and is also a graduate of the Officers School of Military Medicine in Israel. Ranata brings more than 23 years of professional experience as a clinician, a manager, and supervisor in the fields of child protection, mental health, domestic and family violence, PTSD, therapeutic intervention with addicted people, and therapeutic intervention with victims of abuse, including sexual abuse. Her experience has been gained in many sectors, in the army, in government, and in non-government and private practice in Australia and abroad. She manages family support, mental health, youth services, and the all-important volunteer services for Jewish Care. It's a big portfolio, I think you can agree. Please welcome Ranata Leremias.
Hey everyone. I'm sure if I ask you who you associate with the term frontline worker, like me, you would probably say doctors, nurses, paramedics, and firefighters. Frontline conjures up a notion of fighting for life and providing a critical service. The concept of the community-based social worker as a frontliner would not immediately spring to mind. This prompted me to reflect on the role of our community-based social workers at Jewish Care especially in the context of COVID-19. Can we actually be included as part of the team of traditional life-saving frontliners? We social workers work alongside hospitals, clinics, nursing homes, and schools, providing assistance to those experiencing challenging and complex situations such as illness, poverty, disability, abuse, grief and loss, trauma, and discrimination. We help develop and establish the client's natural strengths and do our best to use our resources to remove barriers so as to create environments that welcome and nourish people's self-development and sustainability. During the pandemic, while our attention turned to life in the normal state of emergency and discussions over critical beds and ventilators dominate the news, it was easy to overlook the other realities that unfortunately continued for our clients regardless of COVID-19. In some cases, their fears and problems were exacerbated. With the onset of COVID-19, our organization's 300 committed staff and over 500 volunteers who were not, by the way, classified as a crisis service, suddenly had to mobilize all resources and respond as if we were one. We faced a situation with clients' pre-existing issues suddenly being amplified, and of course, many clients presenting with new urgent issues, including unemployment and severe financial hardship. Those previously at risk of domestic violence and homelessness were at greater risk. Those who were socially isolated or suffered from mental illness were showing signs of greater distress and exacerbated symptomatology. The elderly faced reduced contact with caregivers who needed to wear protective equipment and practice rigorous hygiene protocols. So not only did we suddenly have to reinvent ourselves as a crisis service, but we had to do this with the added constraints of working from home and replacing face-to-face contact with remote access. In a profession that relies so heavily on close interpersonal contact, this new way of functioning presented huge challenges for social workers and our clients. The usual empathic gestures of support and facial expressions were often masked by hazy Zoom screens and faltering technology. The rapidity with which we had to adapt and be flexible in this unprecedented pandemic required professional and emotional agility. We needed to mobilize collaborative partnerships to ensure we could provide wraparound services to meet the complexity of needs presented by our clients. These are our social workers who are often on the front line in complex, uncertain, and developing situations, finding themselves in situations that presented a unique combination of both psychological and physical imminent risks. It is almost as if social workers have Maslow's hierarchy of needs model upside down. Forget about prioritizing your own basic needs. You need to cater for the basic needs of others first. Like other frontline workers, our staff needed to be self-reflective about their own emotional and physical well-being and guard against burnout, as they were often carrying the combined burden of their own stress, as we all were worrying about family and friends locally and around the world, plus experiencing the stress of our clients vicariously. Perhaps more than any other frontline workers, social workers question the human tendency to associate immediate action with importance or criticality of service. I'm sure that for the majority of you in the audience, when trying to think what a frontliner worker is, the idea of being the first responder and providing timely services is a key element. But let's see, how critical do you think it is to continue to support a parent whose loved one took their own life? Or it can wait until after the pandemic? How important is to continue to support a victim of domestic violence or a child who witnesses his mother being constantly let down and abused by his father? And how crucial is to continue to work with his father on how to manage his anger and stop the abuse? So there were so many scenarios where it was obvious that we have to continue our support, like supporting a young family when the mom was diagnosed with a serious illness and she can't anymore look after her children who were needing to be homeschooled when we went into lockdown. Supporting or to support a person with a physical or psychosocial disability to access the National Disability Scheme to ensure their human rights are met. Or making it possible for an isolated person to attend the Shabbat dinner. When dealing with human beings, there are many dimensions of essential needs. It is our responsibility as an organization with our social workers and our staff to not only effectively manage a crisis situation like this, but to establish the infrastructure for our clients and the community whereby a recovery strategy can be implemented. Social workers at every level have the skills and capability to not only address safety for today, but to translate fear, grief, and loss into empowerment and social transformation. For all the reasons above, we continued offering all of our services during COVID-19, and our routine support services not only not reduced in scope, but increased, as the pandemic has many silent victims. There are many assumptions made about our community, and people are often surprised to discover that the Jewish community experiences the same level of social issues as other communities. Yes, there is domestic violence, there is poverty, homelessness, and incarceration. But on the flip side, this is a cohesive, generous, and community-spirited cohort, which is very resourced and has a strong ethos of supporting our most vulnerable members. I feel very fortunate to work in such a supportive environment. Although the pandemic will eventually come to an end and life will go back to normal, I hope, there are a few trends that have taken hold during COVID-19 and are likely to continue in the future. From Jewish Care's perspective, when it comes to promoting the resilience of our community in the longer term, we are heavily investing in strengthening what we call informal caregiving. The isolation that was a forced consequence of COVID-19 is likely to continue gaining momentum in the future, designing to accommodate increased remote work opportunities, virtual realities, and technological advancements. This will increase the importance of people in the immediate circles, like families, in detecting possible deterioration in their loved ones and being responsible for seeking help for them. In a way, these people are becoming our frontline workers, needing to be aware and sufficiently trained in recognizing the signs, providing basic help, and reaching out to us swiftly in a case of an emergency. Failing to establish this informal support system will significantly and adversely affect the communities we serve. We must continue taking the necessary actions today that ensures the continued delivery of quality services to those in need long after the pandemic ends. Reflecting on all I have just told you, I think we can agree that we can hold our heads high as part of that great team of frontline workers, even if we don't arrive with lights and sirens. Our work, quietly behind the scenes, is important to everyone's safety, both physically and mentally. And I take this opportunity to thank everyone in our organization, as well as everyone out there in this space, for the crucial role you play. Thank you.
Thank you, Ranata, and how nice that you also thank your fellow co-workers. Your work reminds us that as we have been so focused on the sort of emergency end of the coronavirus, we have seen so many media presentations about people dying or certainly facing possibly dire illness from the coronavirus. But you remind us that there are a whole lot of other problems that have always been with us and will continue to be, and perhaps are exacerbated by the coronavirus. Ranata, how aware do you think the Australian public is of this ongoing reality? Have they been so completely focused on coronavirus that they've forgotten that there's this giant area of need which is ongoing and that needs servicing on a daily basis?
I think the fact that everyone is experiencing to some degree the impacts of COVID-19 have surfaced and brought to daily attention the issues of mental health, poverty, unemployment, child protection, domestic violence, and so on. In our community, for example, we are seeing a lot of people who never saw our services before, and we often receive the feedback from those people that they were amazed to find out the depth and range of services and supports that there are available. So the open discussions about those topics have amplified, and I believe they do raise the awareness amongst the Australian society. I still feel, although that the media often tends to report the more extreme realities, and issues that are more chronic or have been around for a long time tend not to be reported at the same frequency and scope.
There's a question here from Father Patrick McInerney. What difference does faith make for a provider when addressing clients seeking assistance from social services? Does their faith come into it?
I think the faith, we are a Jewish community or organization, and I think that when we provide services, so many clients, the cultural aspect, it is important for them, and I think that the sense of belonging, it is important for them, and we have we wouldn't be able to provide all our amazing services without the support of the community. And I think that, our clients, or yes, I think that it is important for them that this is a Jewish organization.
How did you maintain the level of commitment and active participation of your volunteer staff during the COVID virus? Was there some trepidation about following through, a fearfulness perhaps in being able to do the usual day-to-day work of Jewish care?
Yes, look, despite the fact that this has been a crisis and probably crazy situation for all of us, except providing constant information and the necessary protective equipment, and putting in place COVID-safe procedures, and providing ongoing supervision, debrief, and training, we did not have to do anything really. Our staffs and volunteers' commitment to the work they do and the commitment to their clients and the community is instilled in them. And they are guided by core professional and Jewish values of respect, community, and communal responsibility, equality, and social justice. So the question was how we continue to support all our existing clients and the new ones, and not if we continue. Actually, most of the innovative and creative recommendations and suggestions about adjustments on how we can continue to deliver all our support were coming, from lower management and non-managerial employers, and we have an overwhelming huge numbers of volunteers who approached us wanting to support the most vulnerable in our community.
So it sounds like just the opposite happened, that because of the coronavirus pandemic, so many people wanted to volunteer and assist and give their all to support Jewish care. But COVID-19 restrictions also had an impact on how ordinary people were able to observe the Jewish festivals, Passover, and then of course the High Holy Days, as well as other festivals following them, and indeed the most important weekly Friday night Shabbat dinner. How did Jewish care, or did Jewish care enable these very important observances to take place? How did Jewish care respond to the religious needs of the community?
Yeah, so Jewish care traditionally celebrated all the festivals with our community for over 80 years. So we try to ensure during the pandemic that the sense of community, togetherness, and the holiness of festival is preserved this year as much as possible, but from a distance. So, for example, in Rosh Hashanah, which is the Jewish New Year, our aged care services compiled a treasury, which in the beginning it was supposed to be a card, but then it became like a mini booklet containing key messages like the meaning of the symbols, the shofar, the honey, the apple, and well as stories of how the holiday is celebrated around the world. And we sent out over 600 of those cards or mini booklets, and it was heartwarming to see how when the staff home visited some clients, to see that they were keeping the cards in their homes, and how important it was for them to have them. Also, because food, as you might know, is important in the Jewish tradition. So we delivered over 250 Passover food parcels and over 300 Rosh Hashanah food parcels, which included specific festival food, because we wanted to make sure that everyone, including the ones that they can't afford, they will have on their table some specific festival food. And also we try to ensure that no one will be alone, and we made sure that all our clients have the necessary technology and are set up and know how to use it to be able to connect with their loved ones, with their synagogue rabbi, and with us, and with the most vulnerable, our staff and field workers accompany them, or they were with them in the night and of the evenings, festive evenings.
Ranata, we only have about a minute before we go to the next speaker, but perhaps I can ask you very briefly. You mentioned the importance of informal caregiving. Can you give us an idea of what you mean by that, and how Jewish care is kind of facilitating that?
Yeah, look, Jewish care has always invested in building community capacity and resilience around issues of mental health, domestic violence, aging, disability, parenting, and employability, as we believe that not only that those are community-wide issues, but it is the responsibility of each community member to be able to recognize the early signs of someone's deterioration and to be the first responder until the more professional support arrives or is available. So one of the examples that we are most proud of it is the Jewish Suicide Prevention Strategy, which has been initiated back in 2017. And the program so far has trained 800 members of our community in mental health and suicide prevention. And we are working on a similar program and campaign in the domain of domestic violence, preventing domestic violence. And we hope to launch later this month our No Abuse campaign.
Well, Ranata, thank you so much for your talk and for answering my questions. And we will certainly come back to other questions that have come in via chat. I think it's a great comfort to know that organizations like Jewish Care are in such capable hands and assisted with such committed hearts. So thank you so much, Ranata. And we will come back to you in the chat afterwards.
Thank you.
Well, our next speaker, Daniel Fleming, is someone I met a few years ago, probably a couple of years ago now, at a Spiritual Care Australia conference. It was a very significant moment in Victoria's history because legislation of voluntary assisted dying had just been passed. And I thought, how is Dan going to respond to this as an ethicist? And he was so eloquent, so extraordinary. It is no wonder that he joins us here today at the Abraham Conference. Dan Fleming joined St. Vincent's Health Australia as the Group Manager, Ethics and Formation. It was a new role that he was appointed to, and he leads ethics, education, advice, and advocacy, as well as formation across the whole group of St. Vincent's Health Australia, which I believe is the largest not-for-profit healthcare system in Australia. It is the first time that a Catholic health organization in Australia has brought ethics into its center in a systematic way. Not that it wasn't there before, but in the past it was more focused in consultant bioethicists and ethics committees. Previously, Dan held the positions of academic dean and senior lecturer in theology and ethics at Broken Bay Institute, a Catholic institute of the Australian Institute of Theological Education. He holds a PhD in moral philosophy and theology and has written on these subjects, including on moral education and religious education and theology. His most recent publications focus on the intersections between religious worldviews and moral courage, something we don't hear enough about in the public square. And I think Dan is making sure it's right there in the center. Please welcome Dan Fleming as our second speaker at the Abraham Conference.
Thank you so much, Rachel. And at the outset, I'd like to acknowledge the traditional custodians of the lands on which we all gather today. In my case, the Wurundjeri people of the Kulin Nations, their elders past, present, and emerging, and any Aboriginal and Torres Strait Islander people who are here with us today. I'm deeply grateful to the organisers of this year's Abraham Conference for inviting me to take part. It's both a privilege and an honour for me to be here alongside my fellow presenters, Ranata and Haroon, in a session led by Rachel. And our theme invites us to focus on both hardship and hope. And what a wonderful sign of hope this event is, bringing together representatives of the three great Abrahamic traditions to reflect on this extraordinary moment in human history. As I hope will become clear in my presentation, I hold the view that our faith traditions are uniquely placed to gift something true, good, and beautiful to our communities in response to the pandemic. The deep anchors of faith offer something essential. And as I will suggest, this offer sheds light on some of the real dark spots that exist in the dominant culture of our time, a form of neoliberal individualism mixed with a rampant consumerism that knows no bounds. As Rachel said, I work for St Vincent's Health Australia, our country's largest not-for-profit and aged care system, which has its home in the tradition of Catholic Christianity and whose mission is served by 20,000 or so staff who reflect the very diversity we cherish here in our Australian community. I offer my reflections from the perspective of the Catholic tradition of ethics, but I address you all in a spirit of mutual dialogue and respect in the hope that together our reflections will serve the common good. So I have the privilege of leading ethics and formation across our national network of health and aged care services. And whilst I haven't literally been at the front line, I have been present to many of our frontliners during these past months and supported them in finding our way through some of the most challenging questions we as a service have ever encountered. What a time it's been to be an ethicist. To give you a sense of this, let me take you back in time a little. It's 12 p.m. on March the 19th, 2020. I'm walking into a meeting with a number of senior executives and clinicians at St Vincent's, which has as its subjects the ethical allocation of resources in the pandemic. Our teams had been watching with anxiousness the story of COVID-19 unfolding around the world and hospital systems similar to ours which simply could not cope with the excessive demand that the pandemic spurred on. In those contexts, clinicians and ethicists were confronting grave questions that they never thought they would need to answer. Questions like, who should we allocate this ventilator to? Who's going to miss out? And on what basis? Stories were emerging about people being allocated resources such as these based merely on their age or some form of criterion such as social worth. These are paths that our health service could never take on account of our long-held ethical commitments, which are founded in the equal dignity of all people, for all are created in the image and likeness of God. That meeting started our process of determining how we would answer these same questions if ever we found ourselves in the same grave situation. And it's right at this extraordinary moment that I think the truth, beauty, and goodness of the faith tradition, which St Vincent's calls home, came to life. And that's because we came to this moment with a long history of bringing that same faith tradition and its commitments to life in other extraordinary moments, and in many rather benign ones as well. Let me take you on a more expansive journey of time travel. First to 1838 and then to the 1980s, and finally this year, before returning to the question which prompted our March the 19th meeting and the way we answered it. So in 1838, 5 women arrived in Sydney Harbour on a stinking hot New Year's Eve after a 4-month voyage from Ireland. Simple chairs with ropes tied to them lowered each of the women into a waiting tender, which took them to the shore of Circular Quay. They walked to St Mary's Cathedral for a mass of welcome and celebration, at which the homilist said of them, "They will seek the bruised, they will pour oil, wine, and balm, the oil of mercy, the wine of charity, and the balm of heavenly consolation." No sooner had Mass finished than they were on their way to Parramatta to begin their service of female prisoners in Australia. Within 20 years, they would establish St Vincent's Hospital, Sydney, one of many such hospitals which would eventually populate Australia's east. These were the first vowed religious sisters to arrive in Australia, 5 sisters of charity who gave their lives in vocation to the love and service of God and neighbour, with a particular focus on those who are poor, sick, and imprisoned. In their lives, they bore witness to an almost literal acceptance of Jesus' demands founded in his own Jewish faith, that his disciples feed the hungry, heal the sick, and accompany those imprisoned. The services that they have established have continued to do so ever since. Fast forwarding a little now, in the 1980s, the HIV Aids epidemic struck Australia. This new disease was shrouded in mystery, and its horrible effects struck fear into the hearts of the community. And as we all know, it had a disproportionately high impact on the gay community. Lack of knowledge around the transmission of HIV/AIDS led many healthcare providers refusing to admit and care for patients for the disease. St Vincent's Hospital in Sydney was a clear exception. In the words of Professor Andrew Carr, who was an immunologist who served patients with the disease during this time, and I quote, "I worked at a lot of hospitals before I started work at St. Vincent's, and I just can't imagine that the care people got would have been remotely the same. There was no judgment, even though for many staff it may have been confronting. But that didn't stop them from looking after the AIDS patients. They were driven by an ethos that we will care for you." That's the end of Professor Carr's quote. Sister Claire Nolan, who was nursing at the hospital at the time and is now the congregational leader for the Sisters of Charity in Australia, said of this moment in time that the choice to provide such care was obvious. In some ways, it wasn't even a choice. It was what the service was made for. It was in its DNA. And finally now, in April this year, a partnership between St. Vincent's Hospital Melbourne, the Brotherhood of St. Lawrence, Launch Housing, Anglicare and Sacred Heart Mission led to the establishment of a service in Fitzroy which has provided accommodation and healthcare for homeless and rough sleepers during the pandemic to keep them safe from COVID and, if they ever had the virus, to isolate and care for them safely. Governance of the facility rests with St. Vincent's, which provides whatever healthcare support is needed to this group at this time. It took just 6 weeks for this 43-bed facility to come into fruition. I'm privileged to work alongside some of the people who were the architects of the idea and who made it happen. I happened to be there for a number of the conversations that led to its funding and eventually inception, including that March the 19th meeting. What struck me during all of this time was an echo of what Sister Claire Nolan said during the HIV AIDS crisis. This really wasn't about choice. It was obvious that this work should be done by this service at this time. In fact, I've never seen a corporate decision-making tree move so quickly on something. It was as natural to do this as it was for the sisters to leave Mass and start serving prisoners in Parramatta way back in 1838. Now, I have a particular love for these stories and many like them, but my focus this afternoon is not simply on sharing the stories, as nice as that is. What I want to hone in on is what these stories and the relative consistency of their presence in the history of the organisation I'm privileged to serve in, especially in recent months, reveal to us about how our faith commitments come to life in the time of radical upheaval we find ourselves in today. Seen in this way, the moment of choosing who to prioritise for an ICU bed is not separate from the decisions that the organisation has made over the last almost 2 centuries. Obviously, that rules out certain paths immediately. We could never allocate resources based on criteria like age, wealth, or social worth. We believe that all people have the same sacred dignity. Instead, we came up with a rigorous framework for resource allocation, which is consistent with our commitments. And perhaps when the discussion time comes around, we could talk about this a little more this afternoon. But if you're interested in reading about it, you can find details about it in the Medical Journal of Australia's online publication, which is called Insight Plus. St. Vincent's Chief Medical Officer, Professor Erwin Lowe, and I have written about our approach a couple of times there over these last months. But what I'd like to offer by way of a reflection on hope in the midst of hardship is a central observation that I think reveals something of the truth, beauty and goodness that our faith traditions bring to a crisis like COVID, precisely because of who we are and how we see the world. And that's illustrated in the fact that for all its gravitas, our March the 19th meeting wasn't our only focus as the pandemic found its way to our shores. It was one small part of a tapestry of responses, which included questions such as, what can we do for the homeless? And how can we ensure that no one would ever die alone in our service? And that Australia's largest not-for-profit health and aged care system had these questions at the centre of its response to the pandemic is surely a sign of hope in the middle of hardship. Thank you very much.
Daniel, thank you very much. And it underlines the importance of faith and that moral imperative that is the foundation of hope, really. However, when you talk about St. Vincent's and its commitment. St. Vincent's is made up of all sorts of people who work for it, doctors, nurses, and all kinds of healthcare workers. And they are often very affected by the secular culture around us. So how challenging is it for you to convey a message that really emerges from a faith perspective, that all people are made in the image of God and therefore are equally sacred? Their lives are equally sacred. We live in a context in which situation ethics and all sorts of other choices are there to be made, either for monetary reasons or otherwise. How challenging is it for you to convey that message to workers in your ethics formation training of them?
Thanks, Rachel. It's a wonderful question. And as with so many questions like this, the answer has a number of different parts to it. But the first one I would start with is the kinds of people who come to work at St. Vincent's typically come to the organization because they see its history, they see what it does today, and they fall in love with it regardless of what their particular worldview is. And so what we experience in our organization, we've done quite a lot of work in trying to understand why it is that our staff come to our organization and why it is that they stay. And one of the reasons they come is because they've fallen in love with the work. So if we think of belief systems, we know that belief systems can kind of exist in our heads and in our cognitive beliefs, but they also exist in our hearts and the way in which we live our lives. And certainly for many of our people, there's a deep resonance in the way in which they want to live their lives and what they want to commit to and what it is that St. Vincent stands for. So that's part of it. A second part of it, though, goes to your question about, well, the services identity is an explicitly religious one. And so when we express our belief in the dignity of the human person, it rests on theological foundations. And within the Catholic tradition, there's a very strong belief that the theological foundations that we exist from should also appeal to people, all people of goodwill. And so as long as one has a bit of practical wisdom about them, one should be able to find language and activity which can bridge between different worldviews to expose a point which is deeply human. And in this context, one of my favorite things to do with our people when teaching about human dignity is to invite them to imagine the person who's most precious to them. And often they'll have in mind a child or a beloved or a parent or a sibling, or maybe it's a best friend. And then what I invite them to do is think about how deeply they value that person, what they hope for that person, how their valuing of that person is in a sense irreplaceable. It doesn't have a monetary value attached to it. And then I suggest to them that really what our tradition is on about is that every person, objectively speaking, has that same value. And it's not hard for people then to get it. And these are already people who have it in their DNA to see someone who the rest of the community might see and walk on by and think we should care for that person. And then it really clicks at a point like that. It finds that resonance in the heart. Mary Aikenhead, who founded the Sisters of Charity, referred to the poor as God's nobility. And people get that, regardless of where they're coming from. So that's the third. And I think, though, Rachel, that your third point there is really, really important in this context. Some of the ethical cards of our communities have been shown during this time. And Ranata made this point as well, and you also made it in your introduction, that this time has been a time of reckoning and coming face to face with our beliefs as they exist. And we've discovered that a lot of our beliefs don't work terribly well during a pandemic. A lot of the things that we think are good and true, once we're faced with a crisis, we see some of their real dark spots. And so in this context, my sense of our people is that they're proud to work for a place which has upheld this tradition of equal human dignity, even in the face of a kind of utilitarian culture which would suggest that some can be cast aside.
Well, Dan, there's only about a minute left in our conversation now before I introduce the next speaker, but I would like to ask you about that extraordinary facility that was established by several churches, Catholic, Anglican, possibly Protestant, the facility for the homeless. In record time, 6 weeks, you can imagine that a local council would take months and would probably exploit the opportunity politically. But there it was. Do you think that in this coronavirus pandemic, religious communities have been shown to be more valuable and more capable than people ever expected?
I think, yeah, there's something to that, definitely, Rachel. And Ranata used the language of certain things are instilled in us and instilled in our people. And there were a lot of people involved in that, and a lot of people worked very hard and got very exhausted, as you can imagine, pulling all that together. But there was a funding stream available because of the way our system functions, that our private hospitals create revenue, which we can hold aside. And some of the people I work with are the people who are the gatekeepers to that and are able to release it. And we're able to release it really quickly. It had support all the way from our board, all the way down, and I think it did from the other organizations. And so there is something about, you know, when you find yourself in a moment of tension and crisis, whatever your DNA is, will come to the surface. And if it's a selfishness, if it's profit seeking, that'll come to the surface. If it's bureaucracy, that'll come to the surface. If it's having a heart for those who might otherwise be forgotten, that will also come to the surface. And in a context like that, when you've got energy around that and motivation, red tape needs to be done still, but it can be worked through.
Well, Dan, unfortunately or fortunately, many of us have walked through the doors of St. Vincent's here in Sydney, and my husband and I often remark on each other, to each other, that whenever we go in, we see friends going in or out. It seems to be the place to be, but I'll never quite see it in the same light. You know, knowing you're there is terrifically comforting and very, very hopeful. So thank you once again for your talk, very inspiring, and answering some of these questions. And I hope we can get to some more a bit later. Thank you, Dan. Well, our next speaker is Haroon Kasim, and he is a hospitalist. And I have to say that I had never heard of the term, but it seems increasingly we need people like him to be across the whole delivery of medical care. Haroon is chair of Health Workstream. He is currently a practicing clinician in New South Wales Health. He has more than a decade of experience in the Australian healthcare system across multiple states and health services. Haroon formally trained for leadership positions within health with a deep understanding of the Australian health system and its networks, which are vast. He is also a part of the Royal Australia College of Physicians Clinical Practice Advisory Committee, Health Reform's Reference Group, and Integrated Care Subgroup. Haroon is a graduate of the Cicada Accelerator Program and Medical Device Commercialization Training Program from New South Wales Health. And he is a passionate advocate of leveraging digital health to enable cost-efficient and patient-centered healthcare systems. And that, of course, involves a lot of home care. And we have seen how important actually those telehealth systems have been in this coronavirus. Haroon is Muslim and is very sensitive to the different needs of ethnic communities in the health system, and is very positive about the ways in which New South Wales Health has been making that happen. So please welcome Haroon Kasim to the Abraham Conference.
Thank you, everyone. So my name is Haroon. I'm a doctor, and I thought I'd start with my story of how I learned to empathize. It is also a story of my learnings on how empathy and faith can help us understand and relate to each other better and create a more compassionate, inclusive, and diverse world. Talking about my learnings to empathize, I'll take you back to early 2000s, where I was a resident doctor in a hospital in rural Australia. And at that time, we had a patient by the name of Jane, who herself was a ex-nurse, who was admitted to the hospital to manage her sorry, my apologies. It's Siri, sorry. So it was early 2000. I was in rural Australia, and Jane gets admitted into our hospital. And Jane is an ex-nurse who unfortunately had terminal cancer and was admitted to manage her pain. Now, the nurses who were there in that hospital did everything to help Jane with her pain. Despite that, for some reason, Jane was very combative, did not quite appreciate the efforts of fellow nursing staff, often very emotive, in considerable angst, and was a very challenging patient. So the nurses called me to address their concerns. I went to the ward and I talked to Jane and I said, look, everything will be okay. Just to be sure, I made sure her pain relief was all right, looked at her prescriptions and made sure that she was getting everything that she needed to get. But yet there was a disconnect. Jane, I'd failed to connect with Jane, and she was still agitated and combative. I was a junior doctor then, so I was at a loss, felt helpless. But luckily, though, a few hours later, I knew I'd come along with my specialist, and we did that. Later that day, we came back and saw Jane with my specialist. Unlike me, the specialist did not concentrate on the medications that were prescribed or just decide to tell her that everything will be okay. He sat next to her and he looked at Jane in the eyes and asked her what was troubling her. Jane went on a tirade for about 10 minutes. He did not interrupt. He just listened silently. And in the end, he said something quite profound. He said, Jane, I have never had a terminal illness before, so I do not know how it feels to die. So I will never know how you feel or understand the fears you feel. But I'm here to help you the way you want me to, because you matter, and you matter to the last moment of your life. It was a rare moment for Jane when a doctor had acknowledged the limits of his ability to understand the fears of people who are dying, because he's just never been there. He was now more human. He empathized, and Jane related to the empathy and honesty. Jane then cried inconsolably. Jane then cried inconsolably and expressed her gratitude to the specialist for being truthful, for trying to be in her shoes and listening to her. Jane's challenges were not with the science of medicine. They related to the challenges in engaging young doctors like me to better understand her needs as a person. She was not a case, she was human first. The solutions did not lie in the realms of prescriptive science. They lay in the uncharted needs of humanity, human emotions, the esoteric, the metaphysical concepts of hereafter and compassion. And in that moment, Jane taught me how to empathize as a doctor. Moving on, a decade or more later, we had COVID. COVID-19 has pushed millions out of their jobs and infected millions more. Hundreds of thousands have died, and more will die from COVID-19. An anticipated wave of mental and behavioral problems is beginning to be documented, compounded by social and economic stresses and uncertainties that are likely present a population health burden for months to years to come. But COVID-19 has also triggered enormous displays of admirable empathy, brought populations together like never before, generating an understanding that our health is interlinked, that we all could be at risk, and the virus does not discriminate. But here's the thing. Is it true that COVID-19 does not discriminate? Evidence is emerging that the effects of COVID, far from being indiscriminate, follow deeply entrenched patterns of health inequities, mirroring burdens of disease that are near universal. Those with resources, money, power, often majority racial or ethnic groups, are better able to physically distance, work from home, and retain their employment. On the contrary, those who are already vulnerable, the unstably housed, people on low income and poorer education, are more likely to become both infected with the virus and die from it. And this is where empathy fails and ultimately calls for compassion as the animating force behind thinking about health. Compassion builds on the empathy that I learned in that it does not motivate our action because we too may be harmed. Compassion motivates actions because the phenomena we observe are unjust, not worthy of the world we like to live in. Our government has done remarkably well and has used the COVID-19 pandemic to embrace cutting-edge digital health to facilitate more just and equitable health systems. And we'll talk about that more during the question time. For instance, we now use cutting-edge geotagging capabilities to effectively contain and spread the COVID-19 virus. And proudly, we have been one of the best countries in the world to do so. We've learned from the COVID-19 virus epidemic and are finding ways and means of helping people, take better care of themselves in their own homes using cutting-edge AI and sensors. This we believe will help us enable health systems that are just, enable equity of access, and help Australians from all social backgrounds better manage their health at home. Compassion, incidentally, is also central to each of the Abrahamic faith. And yet a great deal of escalating violence, terrorism, and bigotry is attributed to Islam. The hijab is often seen as being regressive, and Muslims are routinely required to be apologetic about their faith. Hatred thrives through anti-Semitism and hostility and prejudice directed against Jewish people, and we've had Christian priests who have been arrested and sometimes burned because of spreading their faith. In India, Henry David Thoreau once emphasized the need for empathy and asked, could a greater miracle take place than for us to look through each other's eyes for an instant? Dr. Martin J. Luther King took this further. He spoke of the need for compassion, enjoining on us to see that compassion is just not flinging a coin to a beggar, but to see that the edifices which produces beggars needs restructuring. And today, I ask, could we use the hardship and uncertainty of COVID-19 epidemic to push us to understand and structure a better world, not because we may suffer, but because others are suffering, and that's not how our world should be? Could we use the religion and its inherent emphasis on compassion to help us relate to and understand each other better? Could we use this to help create a pandemic of compassion and enable a world that's diverse, inclusive, and beautiful for our children to live in? Thank you.
Thank you, Haroon, and what a wonderful concept, a pandemic of compassion. But let me ask you about the first kind of human emotion that you learned that was significant for you in the hospital context, and that was empathy. Now, is empathy something you have to keep learning? And does it fade when the volume of patients becomes larger and larger? How does one keep that empathy quotient, as it were, alive and authentic in the day-to-day?
I might just talk about a study that was done in New South Wales, and they talked about, it was a study done around hospitals in New South Wales, and they asked patients, who do you think is a great doctor and who do you relate to best? And they gave them professors and various names, and patients talked about palliative care physicians to be the ones that they relate to the most, and they asked them why. And the answer was they sit down while they talk to us. You see, it's as simple as that. You know, empathy is built on relating and connecting, right? And that's a learning process that goes all your life. So New South Wales actually has, health has a thing called the cultural and linguistically diverse population. And every single person is unique. And how do you build on it? You listen to it. You hear them out, and you relate to it. And yes, if you have too many patients, you don't have the time to listen to people, but you do have the time to be respectful, and that's a good start.
Well, given that empathy is an interpersonal experience and phenomenon that grows, and Ranata also mentioned this in her work, how do you, as a hospitalist, as someone who designs systems of care, or think through how care can be best delivered? I know that you are really interested in digital healthcare. Many people would think of digital healthcare, robots or AI, as sort of disconnecting from the human. They can see it as something, a rather cold phenomenon that is introduced into the healthcare system. How do you think of digital healthcare as a way that can actually enhance a compassionate response to care?
Look, I think digital healthcare thrives in a society that's learned a lot, right? And one of the things that we have learned a lot is, and we learn from other industries. So if you go to most industries, what they like to measure is your experience. If you have a bad experience, you will not engage very well with whatever industry that is. And we've learned that within healthcare, it's no different. Now, if I'm unable to engage a patient very well, the patient will not engage with me. And one thing that determines this engagement is the experience, right? So one way digital health becomes compassionate. So right now, if you were to jump on the internet and look for the Consumer Enablement Forum, which will be accessible to the Agency for Clinical Innovation, one of the points that we measure is the consumer experience. And that means different things to different people, right? My mother comes from an Indian background. If you talk to her in English, that's bad experience for her, right? And there may be a Caucasian person who's very good at English, but feels disrespected by a certain doctor who should, the person away because he was busy. Experience again. So the experience is a soft, fluffy metric that is based on compassion. And that can be measured using digital health with something as simple as smiley faces, right? And more smiley faces, good. If you're having less smiley faces, I'm sorry, there's something wrong. We need to look at it, right? And so what it does is it helps us build an iterative systems that are based on your feelings and that allows us to respond to your feelings with compassion and empathy. And I know it's soft, but it is, and that's how we plan to do that. And a lot of, as a matter of fact, New South Wales Health right now measures how patients perceive the respect they're given. And I must say, I'm proud that about 90% of patients who come into New South Wales Health are comfortable, that they are respected by the healthcare professionals, and I'm proud of that. And that respect is born out of compassion.
I'd like to ask you about something perhaps not so positive that we are seeing develop around us in our popular culture. The challenge of COVID-19 has been seen, understandably and primarily, as a scientific challenge. But and indeed also a technological challenge, as you yourself are working in this field of digital healthcare. But what about the challenge that we are seeing out there in certain sectors of our community that have developed these conspiracy theories in which the virus is attributed to particular groups? It's called the Jew flu in some areas by some groups, anti-Semitic groups. It's been attributed to Muslims or Africans or other ethnic groups. And I wonder if there is a challenge now to the medical profession and people who are leaders in this field to denounce these kinds of conspiracy theories that are circulating on the internet, especially. Is it time for the healthcare industry to step up and to denounce these conspiracy theories that have targeted particular groups?
No, absolutely. And that speaks to what we do, right? If people are not informed about what the actual reason of a particular disease is, they clearly will not be able to comply with what's required to stop the disease from spreading, right? And so, yes, these rumors are horrible, and sometimes it's unfortunate. For instance, and yes, doctors have to step up, but sometimes the leaderships have not been particularly helpful. For instance, there was a leader who we all know, the President of America, who said that, one way of treating COVID is to inject bleach. And, even the best doctors there, like Anthony Fauci, they fail. It's just too much of a fight. But we are not afraid to fight. We will fight. We will stand with people, right? But it can be challenging. There have been times that, we could have been more effective. But again, all I can say is that in Australia, we do a lot better than most countries. And I think that speaks to how well we work as a community, both as a general community and as doctors with each other. And again, I think there's something to be learned there and something really positive about that. Yes, there'll always be negative things, but the ability to know that we have overcome it and others can do that, there's something positive to be said about that.
Indeed. Well, Haroon, I'd like to thank you so much for your talk and specifically for your challenge to us to create a pandemic of compassion. I think that will be sticking in our minds for a long time, wondering how we can do it. And it's also, I'm terribly glad to be in New South Wales, which I know, Haroon, you have said is second to none in the world for
Australia, I must say.
for providing healthcare. So that's great news. I'd like to open it out now and perhaps ask Daniel, just following on that last comment by Haroon about the need to debunk wrong views, distorted perspectives. And Daniel, I know that you have written a couple of articles with the Chief Medical Officer at St. Vincent Health, Professor Lowe, and in particular, debunking some scaremongering. Can you just talk about that particular article and what you needed to, get right?
Thanks, Rachel. Actually, Haroon's challenge is a really good one. And as he said it, I was thinking of that article and remembering the experience of seeing some of what was being said in public, which was effectively, there was an article in the conversation which suggested that if people were to turn up to an emergency department during the COVID-19 pandemic in Victoria, they'd be playing a bit of a game of Russian roulette. So if you chose this hospital, you might get in. But if you were obese or if you were pregnant or something and you chose this hospital, you might miss out, as if there was some kind of background secretive method of distributing resources. And I remember the experience of reading the article and thinking, gosh, somebody should challenge that. Somebody should really. And then this experience of, hang on a second, maybe it's us. Maybe we should be the ones who speak up. So it goes to what you were saying right at the beginning, Rachel, around self-doubt and so on. But in any case, what Owen and I chose to do was say, look, we understand what these authors want. And the good part of their article is they were seeking transparency from healthcare organizations about if there ever was a situation, we haven't seen it, thank goodness, in Australia, even in Victoria's wave, where you had to choose between two different people for an ICU bed. How would you do it? And we totally agree. That should be transparent. We should be very clear about the criteria we're using. But they were misinterpreting a clinical tool as a kind of ethical judgment about who was coming in the door, and suggesting that doctors were, in a sense, computers, that we're using an algorithm to sift people here, there, and everywhere, rather than people trained in a discipline with a practical wisdom, using tools to help inform the best possible decision in a difficult circumstance. So we tried to kind of straighten the record on that particular occasion, but I think it does also relate back to this question of voice and how we use our voice in the public square, because it's been easy to scaremonger during COVID.
It certainly is. I think we're all in a state of sort of simmering fear, certainly about whether we are going to fall victim to the virus. Ranata, I wonder whether the rise in anti-Semitic theories about the origin of the virus ever came home or affected the workers at Jewish Care and the recipients.
No, not necessarily. I think everyone was so busy just to manage, to support everyone. No.
Well, that's good news. Ranata, there's a question here from Zia, I believe. Does Jewish Care have any opportunities to interact with the Muslim community? Has that ever happened?
Look, we are attending all sorts of interagencies, and yes, we meet all the faiths representatives. So yes, and we are very well linked with hospitals and other mainstream organizations, and as we complement mainstream services, yes, definitely. We work together with everyone. And I think that it is very, very important. It doesn't matter the faith, and I think it is very important to work together. There is no other way, I think, to support everyone.
Haroon, I think I should ask you this. How well do the faith communities respond to government directives around the coronavirus? Because the perception is that certain ethnic communities are not obeying the restrictions, perhaps because there have been gatherings, sometimes around religious gatherings. So is that a distorted perception, or what have you found in your experience?
Look, I found, just going back, it's just about treating people with respect and empathizing. And I think our government has done enormously well in that. So, during Eid, they went out and said, hey, look, you guys have done so well, and now we have Eid. Why don't you just be careful now? Just don't gather together. And you see, that's empathy in saying that you have done well, and all we want you to do is help us. There's respect and empathy. And I think that theme has been very consistently replicated. And as far as I know, and please correct me if I'm wrong, I'm not sure that there were religious institutions which came out as super spreaders. There were bars that came out as super spreaders. There were beaches that came out as super spreaders, but I don't think religious institutions did. And there's something to say about that.
Ranata, did you find that the Jewish community was fairly able to follow those restrictions? I know there were some sectors that did not do so very well.
I'm not aware of those sectors. I think that everyone is doing their very best. And I think that it took time also to understand, and probably everyone was still not believing that this is happening. Yeah, I think that there is a very good understanding of the extent, and yeah, I don't think we are experiencing that the Jewish community is not following. As everybody else, probably we are just probably we are a bit concerned that we'll all become a bit complacent, which I hope it won't happen.
Well, we did read in the ultra-Orthodox community, there were some groupings that, you know, the minyans meeting regularly when they shouldn't have. I wondered if you had encountered any of that.
Look, again, I heard about this, and again, it is very difficult. And I think, you know, you then as a ethicist, you know, when people deal with, you know, grief and loss, of course, it's not justified because everyone has to, you know, to comply with the restrictions. Yeah, I do believe that even if this happened, there is a good understanding. There's lots what the community put in place to make sure that everyone is safe and everyone is following proper procedures.
Daniel, I wonder whether the ethical formation that you lead at St. Vincent's has significantly changed because of the coronavirus, or is it the same? And is it an abiding sort of bedrock position that responds to every new challenge that comes down the pike? Or indeed, do ethical codes change over time?
Ethical codes can change over time, though I think one of the wisest positions I heard in the whole pandemic was a bioethicist from Georgetown University, Daniel Leremias, who said something which I've quoted again and again and again. The circumstances are extraordinary, but our principles aren't. And our principles should be able to see us through any circumstance. And if they can't, if we find out that we turn up at a difficult time and our principles are full of injustice, as Haroon suggested, or too narrow in their conception of the human person, as Ranata said, then they probably weren't right all along. It's just that we didn't notice until now. So the ethical framework's the same. Nuances change here and there, and the way we educate about it and the questions we're trying to grapple with from the context of the ethical framework are different ones, but the principles are there. And thank goodness we don't arrive at a pandemic and say, oh, let's forget about our understanding of the sacred dignity in each and every person. Because if we did that, we'd be in real trouble.
Well, I think we can all agree that although the world is in trouble, we are certainly very well served by people like you, Daniel Fleming, Haroon Kasim, and Ranata Leremias. It is wonderful to know that we have you in our community working so hard and in such a dedicated and informed and expert way to help us through this very difficult time. And what is most wonderful, I have to say, about hearing all of you is that deep in your hearts and in your traditions and in the way you go about serving the people in need is that there is an immense degree of hope. And I think hope is probably one of the most powerful and underrated values and perspectives. And I believe that it is very much grounded in our traditions and in the way we view human beings. If I can say, being in the image of God, being sacred, being very special. So I would like to thank you all, Daniel Fleming, Haroon Kasim, and Ranata Leremias, and also perhaps now hand over to Kate, I'm not sure, to Kate Xavier to just acknowledge all the people involved in this wonderful Abraham conference. And let's hope we all meet again soon at the next one. But Kate, can I hand over to you? I think Kate perhaps has not heard me. So perhaps have you heard me? No. I think you are still muted.
I think, Rachel, it's Rod Hyman here, and I think it was then to come to me for a moment.
Oh, my apologies. So Rod Hyman, perhaps you can then give the thanks. Thank you so much, Rod.
Thanks, Rachel. May I start by acknowledging and paying my respects to the traditional custodians of the various lands on which we are gathered today. May I pay my respects to their elders, past, present, and emerging. Oh, wow. Pandemic of empathy. So many lessons this afternoon. Rachel mentioned in her opening the recent passing of Rabbi Lord Jonathan Sacks. So may I borrow from his words, which are most apposite in the context of celebrating the Abrahamic faiths and the commitment our speakers have shown in such practical and perhaps faithful ways. Rabbi Sacks said, "I thank God for the gift of faith, which taught me to see the dazzling goodness and grace that surround us if only we open our eyes and minds. I thank him for helping me understand that faith is not certainty, but the courage to live with uncertainty, not a destination, but the journey itself." I believe that our moderator today, Rachel Conn, our speakers, Dr. Haroon Kasim, Dr. Daniel Fleming, and Ranata Leremias, are the goodness and grace that the Rabbi refers to. The times are certainly uncertain, and their stories have taken us one more step along this journey. To me, they've been an inspiration. So on behalf of all of us, may I say thank you to each of them and ask you all to show your appreciation by clicking on the reactions button with an appropriate reaction. I also particularly thank our committee chaired by Father Patrick McInerney, and which includes Manish Ghosh, Kim Chong, Kate Xavier, Cuddy Hayworth, Ahmed Polat, Shanita Mansour, Abbas Raza Alvi, Zia Ahmed, and Rafat Abid, without whom this conference could not possibly have happened. I also thank all our sponsors, without whose support the conference could not have happened, and who gave our committee the inspiration to bring this conference to its fulfillment under such difficult conditions. May I thank everybody for partaking in this conference, and may I say we look forward to seeing you again next year.